Right.
Good afternoon, or good morning, good evening, everyone, depending on where you're joining from. Today, we are continuing with our Redus Monthly Grand Rounds. This is an important topic that we expect every one of us to listen carefully and learn from the presenter. Esophageal manometry disorders are here with us, but most times we don't talk about it because of diagnostic problem challenges we have in our environment. So it is very important that we pay attention to these meetings so that we'll be able to learn, and from here we can have interest, even in growing our practice in this field. This afternoon, this evening, wherever you're joining from, we have an erudite scholar with us who is going to discuss the topic. His name is Francis Edeani. He's Associate Professor of Medicine. I'm going to hand over to Dr. Lassi to take over from there and introduce him in detail. Thank you.
Thank you so much, Dr. Eva. So today we have the pleasure of having Dr. Francis Edeani to be our guest speaker. Dr. Francis is a gastroenterologist at the Medical College of Wisconsin, where he serves currently as the Gastroenterology Fellowship Program Director. He's also an Associate Professor of Medicine. His clinical and research work centers on esophageal motility and dysphagia, and he has a strong interest in form data diagnosis and management of following disorders. Aside his academic work, he's passionate about medical education and global collaboration in gastroenterology. It might interest you to know that our guest speaker today started his journey in Nigeria and had his medical education at the famous Ahmadu Bello University's area. It's our pleasure to have him with us today, and there is no doubt that we are going to gain a lot at the end of this session. Dr. Edeani, please.
Thank you so much, gentlemen, for your kind introduction. I really appreciate that. It's really a pleasure and an honor to be able to do this grand rounds on behalf of Redus today. Let me make sure my slides are advancing here. All right. So we'll briefly discuss esophageal motility disorders. We know that while manometry is a gold standard for diagnosis, it isn't readily available in Nigeria and in large parts of Africa as a whole. So what do we do? How do we diagnose those patients? With our manometry, of course, we must rely on other practical diagnostic pathways, and that's what most of my talk is going to be about today, relying on EGD and as well as barium esophagram. And I'll try to highlight how you can use this EGD and esophagram effectively to help you reach the diagnosis. Usually when I do these presentations, I like to start off with a case presentation because we're usually dealing with human beings. And this is a patient that I saw in 2020. She's a 36-year-old female that came to see me for a second opinion for gastroesophageal reflux disease that had been going on for 4 years with worsening in the past 2 years. What she described was severe heartburn episodes that occurred every night and would make it impossible for her to get any sleep. She would typically wake up from sleep sometimes with regurgitation in her mouth, and sometimes symptoms would improve with some warm liquids in the middle of the night. She occasionally had nausea, but funny enough, during the day, her heartburn symptoms were less frequent. She also had dysphagia, but she wasn't really complaining of the dysphagia as the way she was complaining about the heartburn. Dysphagia was to both solids and liquids. She described this as a sensation of food getting stuck. She would have to drink a lot of water with her meals. And as we go through this lecture or this talk, you'll see that this is what most patients do when they come in with dysphagia. So other history, she had never had a food impaction, which is important. No pain or dysphagia with swallowing, no coughing or choking with meals. That tells you that this is unlikely to be oropharyngeal dysphagia. She was on twice daily PPI, but funny enough, this made her symptoms worse. She was not taking any other medications. She wasn't on opioids. She wasn't on anticholinergics. Before seeing me in clinic, she had had upper endoscopy twice, and both times the EGD was unremarkable. And then she also had a 96-hour pH monitoring test, which we call the Bravo, and that was normal. So that excluded gastroesophageal reflux disease. Now, when I get these patients in my clinic, the first thing I do would be get an esophagram because that's easier to schedule and readily available. And the image you see is an image of this patient's esophagram. And what you can see here is that with the very first sip of the barium contrast, the patient is already starting to build a column. I don't think I have my highlighter. So the patient is already starting to build a column right here. And then with subsequent sips, you now see that typical characterization of the chalasia, which is a very big appearance, and then a column above it. And with more sips of barium, you see that the esophagus starts to fill up. So I went ahead and got an upper endoscopy, and these findings are characteristic for motility disorder, not necessarily achalasia. You'll find copious amount of saliva in the esophagus. This here is the G junction where the lower esophageal sphincter is, and you can see that there's some tightness there. It's not open. And this is described as puckering of the G junction or the rosette sign. And then you would often find mild dilation of the esophageal lumen. And if you do a retroflexion, which we routinely do, and insufflate here, you'll find that the GE junction here does not open with insufflation. Now, this is not diagnostic for achalasia, but it suggests that there's some tightness here around the scope. So next, I got esophageal manometry, and what you see on your screen is a classic presentation for type 2 achalasia, and I'll talk about that later. So let's talk about why motility disorders matter. In our clinics, these patients are often mislabeled as either GERD or anxiety, and sometimes even dismissed. But we know that if left undiagnosed, those motility disorders would lead to malnutrition, will put the patients at risk for aspiration, and there's a severe impact on their overall quality of life. Now, in resource-low settings like Nigeria, there's often diagnostic delay. By the time these patients are referred, they've been suffering for several years, and I have some data to prove that. So our jobs as healthcare providers, physicians, is to try to close that gap by promptly making that accurate diagnosis so these patients can get the care they need. So let's start off with what normal esophageal physiology or the physiology of normal peristalsis is. So to understand the problem, first we need to understand normal function. And this is what a normal peristalsis looks like. You have contractions happening in the esophagus that are described as coordinated sequential contractions and relaxations that travel from the top of the esophagus to the bottom of the esophagus, with the aim to propagate the bolus in one direction. So the contraction should always be behind the bolus, while the segment of the esophagus in front of the bolus stays open and relaxed. Now, what happens when you have simultaneous contractions happening behind and in front of the bolus is that the bolus gets trapped. And this is what your patients describe as my food is getting stuck. So this next slide here shows what we look at when we're looking at esophageal manometry studies and tracings. What you see here is time and pressure on your y-axis. And then this is pressure. Manometry measures pressures, basically. So at rest, you have a resting esophagus pressure. And then with a swallow, you have a rise in pressure, first in the pharynx. The plot on the right is your isocontour plot, high resolution manometric plot. The plot on the left is your line chart. But you can see I tried to match this together so you can see what's happening at any given time. So up here in the pharynx, a contraction gets generated when you swallow, and the sphincter relaxes and opens up. And that's where you see this drop in pressure here, right? And then it goes back up right here. And then this is what happens in the esophagus. You have sequential contraction at different segments of the esophagus, not all happening at the same time, but at different times that propagates this bolus from the esophagus and into the stomach. So, a brief overview of esophageal motility disorders. There are three broad categories according to the Chicago classification. Achalasia is the one that we're all very familiar with. The types 1, 2, and 3. I won't be talking about those in detail today. There's esophageal gastric junction outflow obstruction. Those two are characterized as disorders of EGJ outflow. And then there's distal esophageal spasm. There's hypercontractile esophagus, both of which are characterized as disorders of peristalsis. And then finally, there's some minor disorders, the main one being ineffective esophageal motility. So this next slide still shows some of what I explained earlier. In a normal peristalsis, a normal swallow, you have your contraction always behind the bolus, with the portion of the esophagus in front of the bolus relaxing. Now, when you have multiple contractions happening throughout the esophagus, you can imagine that the food or the bolus is going to get stuck. And this is what happens with distal esophageal spasm, which used to be called diffuse esophageal spasm. And then, of course, a hypercontractile esophagus is when the contractions are very, very of high amplitude. And what happens here is these patients will typically report chest pain. The typical example here is jackhammer esophagus. And then ineffective esophageal motility is when the contractions are either weak or failed, just not effective enough to successfully clear the esophagus. This last one here is absent contractility, something that you find in patients with, say, scleroderma. And unfortunately, this patient here would mostly rely on gravity to empty the esophagus. All right, we talked a little bit about clinical presentation. You probably know this already, but with motility disorders, the patient will report dysphagia to both solids and liquids right from the start. So that points to a primary motility problem, not a structural problem or a blockage. The patients would sometimes say it's mostly heartburn, and the reason they tell you they have heartburn is not necessarily because they're having acid reflux. The mechanism is different. It's distension of the esophagus by stasis, fluid, some inflammation in the esophagus. And unfortunately for those patients, when they do get some acid reflux, that acid gets trapped in the esophagus because the LES is tight. And then non-cardiac chest pain, that would be a typical patient with, say, jackhammer esophagus. Regurgitation is common. Patients would often say that they eat and then bend over and the food is coming right back out. So knowing the symptom patterns will help guide you towards making the right testing priorities. In the US, we have an opioid epidemic of sorts. So it's very important to exclude opioid use before testing. We make sure our patients are not on opioids or anticholinergics. And sometimes we'll actually have them hold those medications before we do the test. We want you to look for those alarm signs or red flags, which include weight loss, progressive symptoms, or somebody presenting after the age of 50 with new onset dysphagia. That should definitely prompt you to act quickly to make a diagnosis. So I'm going to try to be brief on the diagnostic pathway when we have manometry, which is how we practice here in the US. High resolution manometry remains the gold standard. It is far superior to the old conventional manometry. It is more accurate. It is more reliable. We'll have the Chicago classification that provides standardized interpretation. That way, whether you're in Lagos or you're in Milwaukee, we're all speaking the same language when we read a report. So the first step is always get an endoscopy. I mentioned earlier that I would typically get a esophagram because it gives me like a roadmap. I kind of know what to expect going in. And it's also easier to schedule. But every patient with dysphagia needs an upper endoscopy because we have to rule out malignancy. We have to rule out strictures or eosinophilic esophagitis. So we always get biopsies from both the proximal and the distal esophagus. That's the common practice in the US. So if you have the ability to actually get biopsies and have them analyzed, then I would recommend you do that. Now, the EGD would also give you some indirect clues. For instance, retained food in the esophagus, saliva in the esophagus, evidence of stasis, resistance at the GE junction, all points towards a motility disorder. The next step would be to get your barium esophagram, and here we use a standardized upright timed barium esophagram. The reason we time it is you want to know how much column the patient is holding at 1 and 5 minutes. We also include like a 13 millimeter barium tablet or some marshmallow that is soaked in barium because this challenges the esophagus. And if the dysfunction is subtle, you'll be able to make that stand out. So what we're doing with this is we're getting information on the clearance of the bolus from the esophagus. We're also looking at the anatomical relationships within the esophagus. The classic finding that we all know about is a bird's beak appearance, which I showed in an earlier esophagram image, and also the esophageal rosette appearance, which I'll highlight on a subsequent endoscopy image. Now, it is important to understand that barium esophagram is useful, but it has its limitations. Sensitivity is only 69%, specificity is only 50%. So what that means is a normal barium esophagram does not rule out an esophageal motility disorder. And finally, if you have it, high-resolution manometry is the gold standard, like I said earlier. We do 10 supine swallows. The key here is to include some provocative maneuvers. We would do like a multiple rapid swallow, where we have the patient swallow quickly in quick successions about 5 times, or a rapid drink challenge to kind of stress the esophagus a little bit and elicit some abnormalities that maybe you didn't find before. Overall, using high-resolution manometry has improved diagnostic yield for achalasia compared with the conventional manometry. But more importantly, it allows us to subtype the achalasia to either 1, 2, and 3. And this is important because we know that type 2 responds best to treatment, and type 3 is more challenging to treat. So the type of surgery that we do, whether you do a POEM or whether you do a long helamyotomy or whether you do a regular myotomy, helamyotomy will depend on the type of achalasia. I won't spend too much time on the Chicago classification, but just know that there are 3 major groups. I talked about the disorders of the EGJ outflow obstruction. That would be your type 1, 2 through 3. Achalasia, your EGJ outflow obstruction as well. And the problem with these patients is that they have trouble right at the gate. The lower esophageal sphincter will not open with swallowing. Now, the second category of disorders are what we describe as the disorders of peristalsis. That will be absent contractility, the spasm, and the hypercontractile esophagus. Now, this is a problem with the pump itself. And finally, we have a class that we call the minor disorders. That would be ineffective esophageal motility and fragmented peristalsis. Now, they are called minor disorders because these can be found in some patients that are healthy and completely asymptomatic. So this is what I'm looking at when I interpret or get a study of an esophageal manometry. I talked about what a normal study looks like. You have your baseline upper sphincter up here, you have your baseline lower sphincter here, and you have a peristalsis every time you swallow in a normal subject. So with each swallow, you have opening up here at the upper sphincter, opening down here at the lower sphincter, a nice peristaltic wave that pushes the swallow down into the stomach. Now, everything else is abnormal peristalsis. It's either it's failed, where you don't generate enough contraction force, or contractile vigor to push the bolus down, or it's weak, similar effect, or it's hypercontractile. This is that patient that would complain about pain, chest pain, or dysphagia. And then spastic, this is simultaneous contraction happening at multiple levels at the same time. This is your typical type 3 achalasia. Panesophageal pressurization here is typical for type 2 achalasia. Absent contractility is what you would find in a patient with, say, scleroderma esophagus, where the smooth muscle is completely obliterated. And then you have type 1 achalasia here, where you have failed peristalsis, but also the lower sphincter does not relax. And we have numbers that we use that I don't think I should go into details about. Now, this is what I want to spend most of today talking about. What do you do when you do not have manometry? We know manometry availability is limited in many settings, Nigeria included. The recommendation is that you follow a stepwise approach using what's available to you. And so when manometry is out of reach, we fall back on some core diagnostic principles. Number one, being careful clinical history. This is our most important tool. The story the patient tells, the dysphagia to both solids and liquids, or regurgitation, the chest pain should guide you to diagnosis. And then we proceed with an upper endoscopy. And like I mentioned earlier, you get biopsies. You want to rule out cancer. You want to rule out a stricture. And if we find a stricture, we would usually dilate that stricture. And then eosinophilic esophagitis, of course, is a common disease here in the US. And then proceed to a barium esophagram with a tablet or a marshmallow. If you don't have that in your protocol, I strongly recommend that you do. You're looking for the bird's beak appearance, you're looking for rosette, and you're assessing bolus clearance. So I'm just going to go through this real quick. I talked about solids versus liquids versus both. If you're having dysphagia to both solids and liquids from the get-go, it's probably a motility problem. If you're having dysphagia to solids that progress to dysphagia to liquids, then you worry about a structural problem. And then look for chest pain, response to PPI, because sometimes patients think they have a gastroesophageal reflux disease, but it's actually a motility disorder. And then lastly, medications like opioids can cause swallowing problems. So endoscopic clues to esophageal motility disorder, I already mentioned some of them earlier. A dilated esophagus with retained food or fluid, even after fasting, should immediately raise suspicion for achalasia or at least a motility problem. And when you get to the GE junction, you should feel for resistance. There should be a tight squeeze around your scope. It's not diagnostic, but it's suggestive. If the esophagus looks normal, then and the patient has dysphagia to both solids and liquids, you should suspect that there's a motility problem going on. So this is a patient that I actually scoped that I had a very high suspicion for achalasia for. What you see here on the top left is an endotracheal tube. We intubate these patients because they had high risk for aspiration. The reason being the esophagus is mostly filled with fluid, right? The minute you intubate, the minute you put your scope in, that fluid just comes rushing into the pharynx and your patient could aspirate. So this is a typical rosette sign here. This is the LES or the GE junction, and you can see it's not open at all, even with air insufflation. And then it's dilated, it's wet, it's soaked. That just tells you that there's been some stasis going on for a little bit. So why endoscopy? We do have evidence that it's highly accurate for excluding at least esophageal cancer when you get biopsies. It's more sensitive than a barium esophagram for finding esophagitis. In the absence of manometry, we know that a combination of carefully done endoscopy and barium with some tablet challenge will identify most structural causes of dysphagia. There are some endoscopic clues or signs that will clue you into possible achalasia. I have some pictures on the next slide that look at that. Esophageal rosette sign, there's a ginkgo leaf sign, there's a champagne glass sign, corona sign, pinstripe sign. All this, if present, I mean, you may not have all of this, but in most patients, you have multiple of these present at the same time. In the presence of retained saliva and a puckered G junction, are highly suggestive for achalasia. And here's my slide with all the pictures, what the rosette sign looks like. You see puckering here at the G junction where the LES is. And then you see like radial lines going towards the middle. That's a rosette sign. The ginkgo leaf sign is similar. This achalasia is probably a little bit more advanced than this because the esophagus is dilated proximal to the LES. And then this is a champagne glass sign. This is a pinstripe sign where you have lines like this coming down the esophagus and then it narrows suddenly. And this is a corkscrew. And of course, I talked about having retained saliva. So with barium esophagram, we're all familiar with this, the typical bird's beak sign where you have distension of the esophagus. You can see what looks like some solids in here, all those bubbles and dots that you see. And then, of course, there's narrowing here and dilation of the esophagus proximal to it. And then this is a typical corkscrew esophagus that you see in distal esophageal spasm. And this is what you find in absent contractility. Now, the absent contractility looks very much like the achalasia. The main difference is that this patient has absolutely no contractions here and cannot generate enough force to open up this LES. So we do have some very convincing, reasonable evidence, at least, for the use of barium esophagram for the diagnosis of achalasia. It's just modest. Diagnostic accuracy with a sensitivity of up to 89%, a specificity of up to 91%. And those are actually pretty good numbers. So what we'll typically do is we'll get a double contrast esophagram because then you're able to see tumors, you're able to see esophagitis. And we'll also do some prone single contrast studies that would identify rings or strictures. So a practical upgrade, like I mentioned earlier, to your barium study is just adding that tablet, which significantly boosts your diagnostic yield. There's some data to support that. In some patients with untreated achalasia, with dysphagia to both liquids and solids, they had liquid and tablet transit were abnormal in all 75 patients. But then when it's a patient with just EGJ outflow obstruction, the tablet transit was abnormal despite normal liquid study. So just adding that tablet can help you make some additional diagnoses that you would have otherwise missed. Now, there's a new study that came out, I think it was just this year, looking at using like multiple modalities in trying to make a diagnosis with a barium esophagram, where they're recommended using the esophageal body width, using the EGJ diameter, using the barium height, which is what we currently use alone, and then the passage of the tablet. And just combining all these modalities increases sensitivity to up to 84%, and the specificity improved as well. My next few slides, I'm going to talk about management of achalasia. This is important. The most important thing you can tell your patient is that their disease is not curable, because I think sometimes patients think that if they've had a dilation or if they've had myotomy, they can go and eat whatever they like. It's a lifelong disease. It requires lifelong care. There's a risk of esophageal cancer, squamous cell cancer of the esophagus. So sometimes patients just get their surgery and disappear, but we strongly recommend against doing that because we want to follow up and continue monitoring so we can pick up cancer if they eventually develop cancer. So the management modalities, I'll start with pneumatic dilation for achalasia. There are actually 3 or 4 management modalities. 3 of them are definitive treatment modalities. One of them is a temporizing measure. Starting with the pneumatic dilation, the recommendation is if you can, do a graded approach. Start with 30 millimeters balloon, and then do 35 if needed, and then 40 if needed. The second modality is laparoscopic halemyotomy, and this is surgical. In the US, this is always done with fundoplication. It used to be the gold standard, but POEM, which is peroral endoscopic myotomy, is becoming more available and less invasive. Patients can go home the same day, and it's starting to become the favorite treatment modality for these patients. I talked about a temporizing measure. That would be the Botox injection. We only do this if the patient is unable to undergo um, um, any of the previous interventions for some reason, if they're either too old or too sick to have a surgical intervention. So let's look at the outcomes for pneumatic dilation because this would matter for your practice in Africa. The clinical success rate is pretty reasonable. It's 83% at 3 to 6 months. And when you do like a graded approach where you do 30 and then do 35 and then do 40, that can get up to 90% clinical success rate. And funny enough, this is actually equivalent to halemyotomy at 10 years. At 5 years, the halemyotomy is slightly better, but at 10 years, they both reach the same level of efficacy. Always think about the potential complications of a pneumatic dilation. Do not be aggressive when you dilate the first time. I always recommend go slow, go 30, because if you end up with a perforation, you either should have the ability to deploy a stent, or you have a really good cardiothoracic surgeon to fix that perforation. And now let's look at laparoscopic halemyotomy. The clinical success is excellent. It's 80 to 90% at 2 years. And as we just saw on the previous slide, the long-term success at 10 years is as high as 74%. It's equivalent with the graded dilation, pneumatic dilation, but higher complication risk. The risk for perforation can be as high as 10%. There's always a risk for bleeding. There's always a risk for infection. The patients tend to stay longer in the hospital as opposed to when you do an endoscopic approach. POEM is what we do mostly in the US now. At least my center, my hospital rarely does halemyotomy anymore unless POEM is not indicated in the patient. Pretty high success rate at 2 years, up to 92%. It's not inferior to laparoscopic halemyotomy. Equivalent long-term efficacy, no difference at mean 36 months. So both POEM is superior to the pneumatic dilation that we talked about earlier at 2 years. Now, the key limitation that you have to be aware for POEM is that unlike halemyotomy, where we do a fundoplication, when you do POEM, you're disrupting the LES without giving the patient anything back as an anti-reflux barrier. So there's a high GERD rate in these patients. Almost all those patients would need to be on a PPI therapy indefinitely. So to summarize, both POEM and laparoscopic halemyotomy demonstrate excellent short-term success with clinical success rates around 90%. Pneumatic dilation remains effective, but is slightly less durable initially, while with Botox, you can only provide temporary relief. And like I mentioned earlier, this is something you reserve for poor surgical candidates. Long-term data shows durable symptom control with both POEM and halemyotomy approaching 85 to 90% at 5 years. Pneumatic dilation also demonstrates some declining durability over time. And Botox, like we've talked about a bunch, is just not the best long-term option for treatment. And you can see that clearly on the slide here with still showing the durability over 5 years and a Kaplan-Meier curve here showing the outcomes in 5 years. So this slide looks at the post-GERD risk in patients that have undergone those different treatment modalities. Remember, when you treat achalasia, what you're doing is you're disrupting that barrier between the esophagus and the stomach. So those patients are immediately at risk for acid reflux. poem seems to be the worst because you don't give the patient anything back. These patients will have reflux. Helomyotomy, we usually combine with fundoplication, so less reflux. Pneumatic dilation does not completely obliterate the LES, so they still have reflux, but not as much as the other two. And Botox is the least likely to cause acid reflux. How about the need for reintervention? Reintervention rates are lowest with the surgical and endoscopic myotomy. Pneumatic dilation would often require repeat sessions, sometimes to get the patient to an ECAT score of less than 3. And then, of course, Botox, the longest I've had a patient go with Botox is about 18 months. But it's so variable, it could be anything from just 2 months to 18 months. So I'll spend the next few minutes talking about the African experience, the unique challenges. We've talked about diagnosis and treatment, but let's also ground this in reality of Africa. Achalasia in Africa presents multiple challenges. First of all, it's very largely underdiagnosed. And of course, this is because of the limited access to manometry. You have to rely on barium and endoscopy, which work, of course, but it require you to know exactly what you're looking for. But more importantly, there's a delayed presentation with a mean symptom of 51 months duration before diagnosis, and that's over 4 years. So you can imagine these patients are suffering for 4 years before you see them on average. And then thirdly, patients in Africa are younger. I don't know if it's because we're just not making the diagnosis, or if just the people that present early as children, people with more severe symptoms. Globally, it's about 50 years on average age at presentation. And finally, this is just one study actually out of Algeria that said it wasn't present in 10% of children. But I can also imagine that they also made a comment that most of these children have the outgrowth syndrome, which is a triad of lacrima, achalasia, and adrenal insufficiency. So here's the reality. 75% of achalasia procedures that are done in Africa are still open surgery, of course, because POEM is unavailable. But yet, when these patients do receive treatment, the outcomes are excellent. In one study, they reported 0% mortality, a significant drop in the ECAT score from 9 to 1.5. So that's impressive. So what this means is the problem isn't really treatment quality, it's making the diagnosis. In Algeria, there's a study that showed that just having CME or educational programs to teach physicians about achalasia and the diagnosis improved the diagnosis by nearly 7-fold. So that's the point. The expertise to treat exists, but we need education to close the gap so we can find those patients. I spent some time looking for studies out of Africa on achalasia, and I found a couple. So looking at Nigeria and Ethiopia, we see that there's a consistent story here. The patients are young. The average ages in these studies are from 26 to 35. You can imagine that these studies, the latest was from 2014, so that's a long time ago. Plenty of room for improvement here. So the outcomes speak for themselves. In Zaria, for instance, they reported that 87% of the patients and 6 of 7 children achieved complete symptom relief. In Ethiopia, Addis Ababa, the dysphagia scores dropped significantly. So the takeaway here is that even with limited resources and no access to POEM, surgery delivers excellent results. That said, I think at the minimum, at the very least, we should be able to do pneumatic dilations routinely in Africa. So again, we're seeing similar trend in places like Kenya, where they're actually having more laparoscopic myotomies with very good outcomes. Egypt is the first African country, at least reported in literature, that has achieved 100% technical success and 97% clinical success with POEMs. And then South Africa currently has a high resolution manometry registry. And this is quite encouraging. That's a trend that I think we should keep up in Africa. So the question is no longer asking if advanced care is possible in Africa. We know that it is. And with that, I think we have 20 minutes or so for questions.
Thank you so much, Dr. Francis, for a very beautiful lecture, that has stimulated a lot of interest and questions waiting for you right now in the chat room. Thank you so much. Just before I hand over to Dr. Eva for the Q&A sessions, just to know, in terms of availability of expertise for interpreting esophageal manometry results, we know there is that background problem of having the equipment for esophageal manometry, especially the high resolution esophageal manometry. But in terms of expertise, are there facilities or any information on that people can tap into, even if some centers decide eventually to have the esophageal manometer? I'm not sure of anywhere where it is available in Nigeria.
Yeah, that's actually a very good point. I don't know that it's available in Nigeria. I think, I don't know, but the sense that I get is the obstacle. I don't think it's getting the equipment, right? It's probably, like you said, the training to be able to interpret the studies. I actually have a curriculum that I designed with MC Medical College of Wisconsin. And for the first time, we'll be offering certification courses to Kigali, Rwanda, because they've been able to acquire some manometry equipment. So the resources are available. But the thing with this is if you're going to learn how to interpret and use manometry, you should have the equipment to start with. Because if you're not practicing what you've learned, you'll probably forget about it. So yeah, it's coming to Africa. We're starting with Rwanda. My hope is that at some point I'll be able to offer the same certification courses to other parts of Africa.
Great, thank you. And now hand over to Eva to continue the rest of the Q&A session. Eva.
Dr. Lassie, you may be muted. No, Dr. Evaristus.
Can you hear me now? Can you hear me now, Dr. Edeani?
Yes, I can hear you.
Thank you so much. This is a wonderful presentation. In fact, this topic is rare, and the way you've taken time to break it down to us, I'm sure everybody that's people are making comments. You have really dealt to this topic very well, and we are grateful. Thank you so much. I want to start with the questions from the chat. The first one is, what is the difference between conventional manometry and high-resolution manometry?
That's an excellent question, and I'm glad you asked. So conventional manometry is how we used to do manometry in the past, where we would use like a water-perfused catheter, just the old school pressure gauge devices to measure and put a tube in the esophagus and put water in, and then it will hit some holes, and then we'll attach to a transducer that will now generate pressures of the peristalsis. And the output was basically line pressure. So you can see the pressure go and spike. It was line. So the high resolution manometry was a newer concept, I think came up around 2008 or so, where you can actually see your pressures shown as a color plot. If I could go back to one of those slides. So instead of just having lines as an output and trying to figure out what the pressures are, you have a color contour plot, which just by looking at it, you can tell if it's a normal swallow or not. So the color contour plot goes this way. Blue is low pressure, Then as the pressure increases, the color gets warmer. So this here on the red is high pressure. So this is a high resolution manometry. The catheter is different. It has 36 sensors arranged it has 4 sensors arranged in a circumferential manner and 36 sensors along the probe itself. So it's way more sensitive than what you would get with just what we used to do before as conventional manometry.
Thank you. Very good answer. So the next question is, someone is asking, Dr. Orinye Charles is asking, are there instances where we wouldn't want to do open endoscopy first in a patient who presents with dysphagia?
So personally, I prefer to start with an esophagram. And the simple reason being that, I mean, bottom line is everybody should get an endoscopy if they have dysphagia, because you really don't know, right? It could be a motility problem, but it could also be a mucosal problem, like inflammation from acid reflux, inflammation from eosinophilic esophagitis, and it could be a stricture. But worst of all, it could be a tumor, it could be cancer, right? So everybody should get an endoscopy. Personally, I start with an esophagram because it shows me a roadmap. It tells me how bad the problem is. It tells me whether or not I need this patient to fast for a whole day and then do just clear liquids for like another whole day before I do the endoscopy. And it tells me if I need to intubate them when I'm doing the procedure. So to answer that question, everybody should get an endoscopy. It doesn't have to be endoscopy first. I personally prefer to get an esophagram first.
Thank you. The next question is from Ademola Adeye. Is like looking at the challenges in Africa and how to overcome some of the challenges. So he's asking, using endotracheal intubation to prevent aspiration is ideal, but he's now saying that but because this scale and even where some people are, they may not have access to endotracheal intubation. For him, he says, for patients with achalasia in a resource-constrained environment, I follow this approach. Usually, he takes history, he does examination, and then followed by esophagogram before upper endoscopy. So what he does is, I say, he dilates. First, what he does is he puts NG2 to drain the esophagus before following up. Do you think this is what you can do, what you should do?
Yes, absolutely. I think that's a very resourceful of you to do that. That's very smart thinking to think in that way because you have to use what's available to you, right? So, and we put tubes down the stomach all the time. We put NG tubes in. So this would be a very low risk, resourceful way to try to empty the esophagus because even after you've had the patient not eat for a whole day, sometimes those patients are still filled up, right? So just doing what you do would reduce that risk of aspiration. And then, when you go in, the minute you get in, the first thing you should do is just suction, 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 and try to clear the esophagus as fast as you can. So, but yeah, absolutely. That's a very resourceful way to go about it.
Thank you. He followed up with another comment. I'm happy you started from Nigeria, Dr. Dan, before you moved up to the United States. So you relate with this question. So he said that for medical options in resource-constrained situations, oral calcium channel blockers like nifedipine and long-acting nitrates are options for patients with achalasia where Botox is unavailable. Do you react to this?
Yes. So there's a reason I didn't mention that at all, right? And the reason being that it's not effective, right? It's something, if you think about the physiology of it, you're trying to relax the smooth muscles at the lower esophagus, right? So, in patients with achalasia, We've done studies on this, and I think because we're in the US, we have other options. We go ahead and just do definitive treatment, right? But I can understand if this is all you have to offer your patient, the most important thing would be teaching them on what not to eat. Because sometimes patients do not understand that you can't, solids will not pass, right? So your diet will really have to be blended or liquid diet or puree diet. And if the calcium channel blockers, the nitrates, PD4s, if that's all you have to offer them, then that's all you have to offer them. But you have to follow that with a lot of patient education. Make sure they understand that they can't go and eat a big piece of meat. It's just gonna sit there.
Thank you. One other question, it is from Joy, which she's asking, is there any possible dietary modification to help these patients, especially in our environment?
Absolutely. That's a good question. I think the challenge would be most of these people do not even have the option to pick and choose diet, right? Like, if the gari is your staple, that's what you got. So it becomes tricky, it becomes challenging if the patient doesn't have the financial resources to pick and choose what to eat. Mostly it will be like telling them to make sure that they don't eat. What I tell my patients is if you have to chew it, don't eat it, right? If you've not had your surgery, anything that requires chewing will probably give you some problems going down. So we tell them to stay on a liquid diet mostly. I don't know what the options for that would be in Nigeria. I don't think there'll be a lot of options, but soups may be okay, right? But when you start swallowing eba or, eating meat and yam and all that and rice, those are probably just gonna sit in your esophagus.
Thank you. Next question is from Oluwafemi. She's asking, we talked about POEM as one of the management modalities for patients with achalasia. So she's asking if there is risk of developing esophageal cancer after POEM. Is there any risk from that?
That's a good question. Thanks for asking that. The risk of esophageal cancer is not tied to POEM. It's actually tied to the achalasia. And to be honest with you, we still don't know why that is the case. There's just a slightly higher risk of squamous cell cancer. And, the underlying theory is that chronic stasis in the esophagus causes some mucosal changes that somehow eventually lead to cancer down the line. I think I've had quite a few, maybe 3 patients, not a whole lot, that have developed cancer of the esophagus with underlying achalasia, and none of them had POEM. So POEM as an intervention does not increase your risk for achalasia, not to my knowledge. It's just the risk for cancer, not to my knowledge, but it's actually the achalasia itself and the long-term consequences.
Thank you. Somebody's asking if the regular needle we use for injecting, like in the esophagus or OGJ junction, is the same needle enough for injection of Botox? Because the person has not used Botox before, he wants to know, are there special needles for Botox?
Yeah, so there's a special needle for Botox. It actually comes with a special delivery system. It's like a 5 cm needle that we use here. So just enough to penetrate the mucosa. And we use a lot of the needles that we use for ERCP. So the same for like advanced procedures, not ERCP. We use the same needles, but it wouldn't be the needle that you like. It's similar in length, but it comes attached to a wire, basically. So the wire goes through your scope, right? And then there's a device, you just hook it up outside the patient and inject the Botox. So it's a needle, but it's attached to a long wire that goes through your scope.
Thank you. So some of our, we have a diverse group of people here. ranging from medical students to all manner of special. They're asking some questions. So some are asking, are there any way, some programs that people can learn from, like training courses that people can begin to learn? Because this is what you are presenting is sometimes people don't get to do much in it because of the awkward limitation you highlighted even as you were starting. So it's asking, is it possible for some training courses? Would you want to have a program like that where you develop some training courses for people that people can tap in? And in addition, another question that will follow up is the next question. Having developed a program, this collaboration in Rwanda, is there any plan to extend it to other bodies in Africa so that beyond Rwanda, others can also tap into it?
Absolutely. Naturally, that's my plan. That's my long-term goal. I want to increase the knowledge about this disease. I want to be able to empower people to actually make that diagnosis. And, hopefully we'll catch up because I feel like Africa is so far behind. And that was one of the main reasons I actually chose a specialty. I spent an extra 2 years just doing esophageal motility as a course. So because it's something that very few people know about, right? Even amongst physicians, sometimes in the US, the number of people that are trained in this specialty are few. So my hope is to be able to export that knowledge to Africa. We're just starting with Rwanda because they already have the infrastructure, they have the equipment. So it's going to be the same training, it's going to be the same modules. There'll be some certification from MCW. But again, it's useful to you if you have the infrastructure to actually perform the test. As a matter of just general knowledge, just trying to learn more, there are a lot of online resources that you could tap into. Even on YouTube, for instance, you could find videos on esophageal motility disorders.
Thank you. We have a few minutes to go. Another question is it possible to have poem or fund application without first having the patient do manometry, high resolution manometry?
So that's an excellent question. It's possible to do that, right? If you have a very high index of suspicion. And I think the bulk of this talk was to explore other ways of getting to a reasonable diagnosis of achalasia without manometry. So if you have all these combination findings, before manometry became available, we were diagnosing achalasia, right? In the 80s, before manometry became broadly available, people were just using barium esophagram. Achalasia is actually easy to diagnose because of the classic presentation, right? You do an endoscopy, you do your barium esophagram, and you can conclusively say, okay, with at least a certain percentage of confidence or degree of confidence that this is achalasia. So if you reach that conclusion, it's reasonable. You can go ahead and get poem. Not everybody has access to manometry.
Thank you. The next question is almost random all the questions, but before the program in Rwanda takes off, we don't know how long the program will take off. Assuming, are there opportunities for those who want to advance their career in esophageal manometry? Are there opportunities out there? Even if a program starts, it will not have the volume. It will take some time for somebody to have that volume in training in Africa. Is there any opportunity for somebody to the one or 2% to train, get to train outside?
Yeah, absolutely. Absolutely. Like, I have a few motility centers in the US, right? And most of them would actually provide that opportunity for you to come in and actually get hands-on training, which would be you see how the procedures are done, you see how the interpretation is done. So there's opportunities out there.
Thank you. The last question will be for you to actually make you want to ask you, what are your hobbies?
Oh God. So I like sports. So I mostly I watch a lot of sports. So that's fun. I also like just spending time with friends and family. Um, yeah. We get so busy around here that you have little time for anything else, but yeah.
Thank you
Thanks for
very much.
asking.
Thank you very much. So we're excited. You can see the excitement. People are asking questions. So many people are glued. So many are listening because this is a very unique topic for us here. So I'm going to hand over to Dr. Lassie to make the final state of the comments and before we wrap it up. Over to you, Lassie.
Thank you so much, Dr. Evan. Thank you, Francis, for this master class. As you can see, we still have some few questions that are yet to be attended. I think it's a discussion that people really enjoyed and benefited from, and I hope you'll be available through the back end to attend to this question and channel it to you and then get across to them.
Yes.
The social media platforms, people are asking for recording to some couldn't join and they actually feel that. So it's been a wonderful outing today. We've gained a lot. We are grateful to our seniors, our teachers, and the president of the Nigerian Society for Colorectal Disease, Professor Ade, was here and shared a lot of his experience and asked questions too. And so many other teachers and mentors that are here, the students, the nurses. These are feel like they go from diverse field. We are very grateful to all for joining and making this an interactive session. And to our guest speaker, thank you again for all the education we received. And I don't know if Kene is on the call to make some few comments before we wrap it up.
Good afternoon, everyone.
Good afternoon.
Yeah, this was a fantastic presentation, Dr. Francis. I want to thank you again for making the time to prepare this and talk to us about it. Like you said, we are catching up in Nigeria, but we are on that journey, and we hope that with your help, we can just begin to improve access to knowledge on motility disorders because these things are much more common than we realize. But thank you again.
Yeah, thanks for the invitation. It was a pleasure. And if there are any questions, I know it's just an hour, please feel free. That can be sent to me. I'll be more than happy to respond to them.
Thank you so much. And for those that don't know, Kene.
You are muted, Dr. Lassie. We can hear you.
Okay, sorry, I said for those that don't know, Kene is the CEO of Redus Center for Digestive Health here in Lekki. He is a gastroenterologist with his area of specialties in advanced endoscopy, and he practices in the US as well. We are very grateful to you, sir, for initiating this, and we are happy to have you make some comments at the end. So everyone, thank you so much for coming around today, and let's have another beautiful session next month, and we'll get across to us with the links and topics. Thank you so much. And let's
All
have a
right,
wonderful
thank you.
Bye.
Bye.
Thank you.